Michael, today we want to talk briefly about pharmacogenetics and how it might apply to the mental health field. Pharmacogenetics is an area of medicine where we're trying to explore differences, biologic differences in patients that might explain wide variation in treatment response.
I'm really excited where this area of medicine's going, and in particular how pharmacogenetic information might be applied and implemented to improve the outcome of our depressed patients. And this leads us right into talking about the PRIME Care study, a large-scale implementation project being funded by the VA.
Yeah, so Michael, as you know, we're both very involved in the leadership of that project. The design of the study is really focused on two principal issues. One is, do providers and patients use genetic results in their practice? So will they take the results of testing and actually change the way they practice? We are focusing on veterans with major depression in the study. It's a very common disorder for veterans, and also we can measure response more easily. The other issue then is whether the veterans get better from this treatment. So if you use these tests in practice to make choices around the treatment, does it actually lead to better outcomes? There's also a number of secondary measures that we're looking at in terms of side effects and other things.
So these sound like really important topics to do a study, and I wonder if you could tell us a little bit more specifically about the design and the methods.
Right, so the design is a randomized clinical trial. We're randomly assigning veterans to getting the results of the pharmacogenetic testing back right away. It takes about 48 hours to get it back to the provider. In that arm, what we're studying is whether the providers actually use those results and do the patients understand them in a way that influences the treatment choice at that point in time. The other half of the veterans are being randomly assigned to usual care, so they'll be followed for 6 months getting care as they normally would have. We do give the results of the genetic testing back to them at the end of that 6 months, though. That leads me to think about the other factors that we had to think about in designing this trial. And I wonder if you could speak to that a little bit, Michael.
Of course, Dave. And whenever you do a study of antidepressants, you always have to keep in mind that the process of care is actually more important. It has more to do with the outcome than the actual drug itself. And in our particular case here, now we have the actual drug and the way the drug is modified by the pharmacogenetics. And then, of course, there's the patient and all that he or she brings to the care process. And we keep in mind that in our studies of antidepressants, there's only a 50% chance of success, and about 2/3, 3/4 of that is accounted for by non-specific factors. So we need to have a large sample in order to do this. But of course, the large sample enables us also to take into account the unique aspects of the VA care setting, our older patient population, their more highly comorbid conditions, and the way health behaviors like tobacco smoking might influence the use of the pharmacogenetic test themselves. And then, of course, we have the opportunity, in addition, to learn about the doctor-patient interaction, how the doctor uses the information and engages the patient, and the patient's perception about how the whole care process has been modified or changed. There's a really interesting opportunity to learn a lot of things over and above simply whether the test result makes a difference. And I must say that this particular test result represents where things are right now, but I know you're also excited about the opportunity to see this information expand in the future. So could you tell us a little bit about the discovery aspect of the study?
Yeah, that's a very important part to this. As you just mentioned, it's not clear that the test that we have today is going to be the test that we need tomorrow. We've built in a lot of discovery aspects to the trial. We're doing whole genome sequencing. We're looking at antidepressant levels and a number of discovery aspects, and I think that's very, very important. Another discovery area is actually the knowledge dissemination piece too, learning how to teach providers how to use this information. I think all of those are very exciting to me.
So I think that is a clear added value of our study, and it doesn't matter so much whether the new information adds 2% or 4% or 6% to the chances of remission. That's important in and of itself, but even more important is the chance to learn more and to further improve the way we deliver care, making use of these new both pharmacogenetic and implementation pieces of information.
Yes, and Just in sum, I'd like to thank all the providers and the patients that have participated or will participate in this trial. It's so valuable as a learning experience for everybody. And thank you.